Hello, everyone. Welcome to my YouTube channel, where I make pharmacology simple for everyone to understand. Today, I want us to look at anti-asthmatic agents. I'm Professor Kennedy Eden Kukuya. So what exactly is asthma? So asthma is normally described as an inflammatory condition of the airways that is characterized by recurrent, reversible airways obstruction. Recurrent, reversible airways obstruction. Now, these airways obstruction come as a result of the inflammatory condition that is happening. It also happens because of the bronchoconstriction or bronchospasm. There are various mediators that contribute to this. Sometimes we have infiltration of various inflammatory or immune cells like eosinophils. We have certain antibodies like anti-immunoglobulin E that contributes to the condition. Now, when people have asthma, we normally put it in this way so that it is easy to appreciate. So we normally talk about the features of asthma. One, we talk about reversible airways obstruction. Two, we talk about bronchial hyperactivity. And then three, we mention the airway inflammation. Now, these features are what we look at to decide on the drugs to give. And so the reversible airways obstruction, we have drugs that will target that, and then bronchial hyperactivity and then airway inflammation. Those also we have drugs that will target that. Now let's get into the details. So let's assume that my patient has asthma and we are saying that there is reversible airways obstruction. So there is some bronchoconstriction. The bronchioles are constricted. How do we get the bronchioles from this place to that? All right. Normally, we give them certain medications. Some of these medications or a number of these medications, they inhale them, and that gets us to the second scenario where the constricted bronchiole gets dilated. But how do these drugs work? Let's understand the mechanisms. Now, you need to understand that there are mediators that could cause that bronchoconstriction, and then there are mediators that could enhance the dilation of the bronchioles. So if we know the mediators that cause the bronchoconstriction, we could give drugs that inhibit their action, or if we know the mediators that cause the bronchodilation, we could give drugs that enhance their action or drugs that mimic their action. So I would go into the details in terms of mediators that cause the bronchoconstriction. We have acetylcholine. Then we have leukotriene. So these act on their respective receptors to cause bronchoconstriction. Then when we come to those that cause the bronchodilation, we could talk about adrenaline or epinephrine. Then we could talk about cyclic AMP or cyclic GMP. So meaning that if I gave a drug, the drug would either block the action of acetylcholine or leukotrienes, or the drug is going to act like adrenaline or enhance the activity of cyclic AMP and cyclic GMP. Now let's take a step further and look at the details. So let's pick the first scenario. The bronchioles are constricted, but I want to get it to become dilated. Okay. Now, let's assume that in the airways, we have certain receptors. So here we have beta-2 receptors that adrenaline can bind to. Now, when adrenaline binds to that receptor, it activates the receptor and then causes the smooth muscles to relax. So we have bronchodilation. And so if I then give you drugs that work like adrenaline, mimic the action of adrenaline on the beta-2 receptors, these drugs can then move us from this constricted situation to the dilated situation. This is the basis of giving the beta-2 receptor agonist. Very simple. Now, we divide these drugs into short-acting agents such as salbutamol, also known as albuterol. We have terbutaline, we have methylpyridinol, levalbuterol, and then perbuterol. Then we also have long-acting agents like formoterol, salmeterol, aformoterol. Then the ultra long-acting, we have indacaterol, olodaterol, and then vilanterol. Usually, the short-acting agents, we use them as and when it is needed. We tend to call them relievers, and they have short duration of action. They work very rapidly, and so when the patient has an attack or about to have an attack or is going to engage in an activity that could easily cause an attack, they tend to use those. But the long-acting and the ultra-long-acting agents, we tend to use them at regular times. So long-acting could be used twice a day. Ultra-long-acting could be used once a day. And normally, long-acting, ultra-long-acting, we tend to advise that they should not be used alone to prevent asthma, asthmatic attack. We tend to use them together with steroids. Otherwise, they worsen the person's condition. Some few side effects patient could complain of tremors, there could be headache, there could be increase in the heart rate we call tachycardia or dysrhythmias. These are the common adverse effects related to these drugs. Otherwise, they are well tolerated. And irrespective of what kind of drug or what kind of situation causes the asthmatic attack, these drugs are useful in reversing the bronchoconstriction. Then we go to another class of drugs. Now, picture a scenario where you have ATP or GTP. ATP is acted on by adenylate cyclase, converted to cyclic AMP, and then GTP acted on by guanylyl cyclase, and then converted to cyclic GMP. Cyclic AMP, cyclic GMP acted on by another enzyme called phosphodiesterase, will then convert them to AMP in the case of cyclic AMP, and then GMP in the case of cyclic GMP. Now, cyclic AMP and GMP, these have the ability to cause bronchial smooth muscle relaxation. GMP and AMP do not, so they do not have that bronchial smooth muscle relaxant effect. So allowing the phosphodiesterase to keep working means that we are going to reduce the levels of cyclic AMP, cyclic GMP, which will worsen the asthmatic condition. And so the drugs that we give, these drugs could inhibit the action of the phosphodiesterase. By so doing, conversion of cyclic AMP or cyclic GMP to their metabolites, AMP and GMP respectively, will be reduced. That way, it means that cyclic AMP levels go up, cyclic GMP levels go up. And since they have bronchial relaxant activity, they are able to reverse the bronchoconstricted situation. And we have two examples. We have theophylline, we have aminophylline. Theophylline can be given orally, aminophylline is given IV. Now, these drugs have narrow therapeutic index, and so using them, we should normally advise that we follow through with monitoring of the plasma concentration. Otherwise, we have trouble. Now, remember how we said they work. They cause increase in the levels of cyclic AMP, cyclic GMP. Now, when cyclic AMP levels increase in the heart, this could lead to increase in the levels of calcium, which can increase heart rate and force of contraction. We are likely to have some tachycardia, which may be fatal as a result of the increased heart rate. Now, cyclic AMP levels rising in the brain could cause stimulation of the neurons, and that could lead to seizures, which could also be fatal. But the other form of it is that we could consider the fact that they could stimulate respiration, and for this purpose, theophylline can be used as a respiratory stimulant. That is a positive. But otherwise, these drugs need to be monitored because of their narrow therapeutic index and the tendency to easily cause toxicity that could kill the patient. And so if the patient is on other drugs together with theophylline, we need to ask, are these drugs increasing the elimination of theophylline or reducing the elimination of theophylline? That can help us know how to make adjustment. We come to the next drug that could cause or could reverse the bronchoconstriction. Now, picture a scenario like this where your bronchial smooth muscle have they have M3 receptors. These M3 receptors, acetylcholine, ACH, is supposed to work on them. And then by working on this, we have bronchoconstriction, as we mentioned a bit earlier. Now, if we don't want this bronchoconstriction, what do? We give a drug that blocks the action of acetylcholine on this M3 receptors, and that ensures that we don't have the bronchoconstriction, we have bronchodilation. And so examples of these drugs, we have ipratropium, we have tiotropium. Ipratropium is short-acting, tiotropium is longer-acting in duration. Ipratropium has a quaternary ammonium structure that makes it charged. So when it is given by inhalation, the drug tends to stay within the airways more, and so we have less adverse effects when the drug is given. So that's something you need to know about. Now, because of the fact that stimulating M3 receptors in the airways could cause release of mucus secretions, which will worsen the asthmatic situation, giving these drugs would reduce the mucus secretion, and that is very useful, especially when you have patients that have asthma and are also coughing. These anti-muscarinic agents are very, very useful. They are also well tolerated. Then we come to the next bronchodilator called leukotriene receptor antagonists. We could also call them cysteinal leukotriene receptor antagonists. Sometimes we call them LUCASTs. Right, now let's get into the details. So these drugs, how do they work? Picture a situation where you have a metabolite called arachidonic acid, which is coming from phospholipids. This arachidonic acid is acted on by lipooxygenase LOX, and then we produce leukotrienes. Leukotrienes then cause bronchoconstriction by working on the receptors, the leukotriene receptors. Now, we could decide to block this enzyme and then reduce the production of leukotrienes. There are drugs that work like that, but we'll talk about them later because they are not bronchodilators. But then we could also give a drug that blocks the receptor on which the leukotrienes act on. And so instead of bronchoconstriction, we have bronchodilation. And I said these drugs are called LUCASTs because of the fact that their suffixes end with LUCAST. So we have montelukast, zafirlukast, pranlukast. They are very good agents, well tolerated. Otherwise, there are some few adverse effects, such as insomnia. There are gastrointestinal disturbances that we need to be aware of. They are very, very good agents. Now we come to addressing the inflammation. Remember, we said that asthma was an inflammatory condition. Now, although we are not curing the asthma, we could find a way of ensuring that we address the inflammatory processes that ensure that the patient's quality of life could be improved. So in dealing with the inflammation, we need to be aware of certain mediators that play a role. One, we have histamine contributing to the inflammation. So histamine comes from the mast cells when there is degranulation. So this releases histamine, and histamine could cause bronchoconstriction, but then it could also contribute to the inflammatory response. Two, we have immunoglobulin E, which is an antibody contributing to the inflammatory response. We have various immune cells like monocytes, eosinophils, T cells, all contributing to the inflammatory response. So the drugs that we give, what they do is to either reduce the mediators, the chemical mediators that play a role, or they could work by reducing the proliferation of the cells that contribute to the inflammatory response in asthma, or they reduce the movement of these cells or the infiltration of these cells into the airways. And so we will look at how these drugs work quickly. So one, we talk about the mast cell stabilizers. We have examples such as sodium chromoglycate, also known as cromolyn sodium, and then nedocromil. Now, these drugs, from their name, they work by stabilizing the membrane of the mast cells so that instead of releasing histamine, we do not release the histamine. Someone would have thought that, okay, since histamine contributes to the inflammatory response and the constriction, that is how these drugs work, but we are not too sure how they work because we know that there are other drugs that are mast cell stabilizers working better than these ones, but do not have any role in asthma. So there are other mechanisms that we are not so sure of, but at least we know that these drugs work in people that have asthma in helping with the inflammatory situation. The next class of drugs we would like to look at will be the glucocorticoids. These have, let me say, one of the broadest spectrum of anti-inflammatory activity. They work by reducing the production of chemical mediators that contribute to asthma, the asthmatic attack or the inflammation. They reduce the infiltration of cells such as the eosinophils, the T cells, and then their proliferation. And so by reducing all of these, various mechanisms are at play. By doing this, the inflammatory condition is suppressed in a way, okay? And we have various examples. Some of them are used as inhalation agents, others are used as systemic drugs. So we have fluticasone, metazone, budesonide, cyclisonide, hydrocortisone, dexamethasone, prednisolone. There are other examples, prednisone, methylprednisolone. So we could go on and on and on. And these drugs are very useful. They take care of both the early and late phase of asthmatic attack. And we could use them for other conditions, but very, very crucial agents in the management of asthma. We tend to call them controllers, okay? And so let's delve a little bit into some of the adverse effects of glucocorticoids. Although glucocorticoids are very effective, they are very useful in asthma, they come with a number of adverse effects, such as the suppression of the adrenocortical system, or let me say the adrenal gland. So they suppress the production of certain steroids, and that could have some disastrous effects. But there are some agents that do not do that, like fluticasone, mometasone. We also have the situation where, because of the way they suppress the immune system, they tend to cause the growth of certain fungi like candida. So people can have oropharyngeal candidiasis. And there are, in terms of using the systemic agents for a long time, there is the possibility of hypertension, there is a possibility of Cushing syndrome, there is a possibility of let's say fluid retention. There is also that possibility of ulcer that some patients could have. So these are some few adverse effects related to the glucocorticoids. I think that this captures it pretty much. Then we come to what we call the biologic immunomodulators, or simply the biologics. Now, these biologics, these are monoclonal antibodies usually that are produced to address some of the processes that contribute to the inflammation. They are quite expensive, but they could be an option for some of the patients, especially those who have what we call eosinophilic asthma, could benefit a lot from these biologic immunomodulators. So we have various examples. We have the anti-immunoglobulin E antibodies, such as omalizumab. We have interleukin-5 inhibitors, such as benralizumab, mepolizumab, reslizumab. Then lastly, we have interleukin-4 receptor inhibitors called dupilumab. And so these are the various agents that we use in the management of asthma. I believe that you've enjoyed this lecture. Do subscribe, to our channel for more videos. We hope to see you.